So this is the second of the head and neck anatomy webinars. The hypoglossal nerve is the last, of course, of the cranial nerves. It's the 12th nerve. It passes out through the skull in the hypoglossal canal, which is just in front of the foramen magnum by the condyles. And the nerve passes forward fairly horizontally and passes through into the base of the tongue. It's a purely motor nerve. It has no sensory function at all, and it innervates the intrinsic tongue muscle, but also the extrinsic muscles, the muscles that connect the tongue to the mandible, to the hyoid, and so on, except for one muscle. But we don't need to worry about the details of which muscle is innervated by the hypoglossal. Palatoglossus, I think, is vagus, but we don't need to worry about those details. And of course, when we do a cranial nerve examination, we often test the hypoglossal nerve, the 12th nerve, by asking the patient to move their tongue from side to side, and of course looking at the tongue to see if there's any wasting or any fasciculation. So that's the hypoglossal nerve. Moving on to the maxillary nerve, which is part of the trigeminal, because we're going to be talking quite a bit about the maxillary nerve. So in the trigeminal nerve, of course, there's three main divisions: the ophthalmic, the maxillary, and the mandibular division. Each of them come from the trigeminal ganglion, which sits just inside the skull, and then they pass out through the skull. And the maxillary division comes out through the foramen rotundum. And it more or less goes straight ahead. It goes across something called the pterygopalatine fossa, which we'll meet in a moment, and then it runs in the floor of the orbit before going back into bone again, and then appearing just below the eye in the infraorbital foramen. And more or less, the infraorbital nerve, where it comes out on the face, is more or less a straight line continuation of the maxillary nerve. And it's a fairly substantial terminal branch. But on its way through the bone, the maxillary nerve gives off a lot of branches to the superior teeth. And we can see those branches here forming a sort of plexus of nerves over the upper teeth. There's both an anterior and a posterior superior alveolar nerve. So superior alveolar being to the alveolar bone of the upper jaw. Of course, there's an inferior alveolar nerve, which we'll come back to again later. But the superior alveolar nerves, of course, innervate the teeth, very important to dentists. Quite tricky to get at, and we'll come back to how you can try and block at least part of that a little bit later. But those are all branches of the maxillary nerve as it runs through the bone before finally coming out on the face. So as well as that final branch, the infraorbital nerve, we've also talked earlier about the other two sensory branches, the zygomatico-frontal and the zygomatico-facial, which come out over the cheek, over the prominence of the maxilla, and then provide sensation to the skin above and in front of the ear. We're not concerned with those at the moment. Those are the sensory branches. We're just going to be focusing more on what the maxillary nerve does within the head. So the maxillary nerve provides a lot of the sensation within the nose. It also has branches which run to a large part of the meninges. Of course, the meninges are sensitive. That's why we get pain with meningitis and so on. And a lot of that runs in the maxillary, a branch that comes into the maxillary nerve. It's called the meningeal nerve. But in addition, the maxillary nerve has branches to most of the sinuses and also to most of the nasal cavity. And this picture here shows the sensory supply within the nasal cavity, and it also does the palate and the upper teeth, etc. It also does a large part of the pharyngeal wall. Of course, the glossopharyngeal and the vagus, also important in innervation of the pharyngeal wall further down. In addition, the maxillary nerve carries the parasympathetic innervation to the lacrimal gland. Now, we don't need to worry about the route by which the parasympathetic innervation got to the maxillary nerve, because it didn't come with it all the way. It came across in something called the greater petrosal nerve, which we don't need to concern ourselves with. But it from the point at which that joins, the parasympathetic supply to the lacrimal gland runs in the maxillary nerve. I thought it might be helpful just to run over the parasympathetic innervation in the head. So what are the things that are driven by parasympathetic nerves? Well, they drive all of the secretions. So the salivary secretions, the parotid, the submandibular and the sublingual glands, but also the tears, the lacrimal glands, and the nasal mucosa. The nasal mucosa can have what's often known as vasomotor rhinitis. You can have a lot of fluid production by the nasal mucosa. And then, of course, the pupil. The pupil is constricted by the parasympathetic supply. So just put all this stuff into a table here with the function and the ganglion and the nerve pathway. So the parotid, it's the otic ganglion, and that travels in the glossopharyngeal, and then V3. Now V3 is an abbreviation for the third division of the fifth nerve. So that's the third division of the trigeminal nerve, which of course is the mandibular. And similarly, and I don't think the college expects us to know the detail of this particularly, but the submandibular and sublingual glands, those are both innervated by the submandibular ganglion, which sits just very close to the base of the tongue and gets its fibers from the chorda tympani. The lacrimal gland that we've just been looking at gets its supply in the maxillary nerve, and its synapses are in the pterygopalatine ganglion. And finally, the ciliary ganglion is where the synapses for the pupil are, and that sits it right in the back of the orbit. So those are there are 4 parasympathetic ganglia in the head, just the 4. Okay, there are other ganglia in the head like the geniculate, which we don't need to worry about, which is on the facial nerve, but these are the parasympathetic ganglia. Okay. The college curriculum mentions that we need to know about the pterygopalatine fossa, so I've indicated it in this picture here. It's got the foramen rotundum at the back of it, and it's basically, it sits behind the maxillary sinus really. You can't see it very clearly from this angle. This is not looking straight down, this is sort of looking forward. So it's inside the ramus of the mandible, medial to that, and behind the maxillary sinus. That's the pterygopalatine fossa, and it's got a few important structures in it. Let's focus now more on the nasal cavity itself. Now, of course, the nasal cavity is divided in 2 by the septum down the middle, and the septum, of course, is cartilaginous at the front, so that's shown in blue here, and then behind that it's bony. And there's different components to the bony septum. We don't need to worry about the details of it. But of course the cartilaginous part is vulnerable to clinical problems. So from vasospasm, from cocaine use, it can suffer necrosis. And so cocaine users who sniff cocaine can end up with a hole in the septum and a perforated septum. And of course it can also be the site of hematoma formation from trauma, and a hematoma can also lead to necrosis of the cartilage and collapse of the centre of the nose and an odd appearance of the face, the typical boxer's nose. And then behind that you've got the more rigid bony septum. So that's the centre of the nose, the septum. If you imagine you cut the head down the middle and looked at the lateral wall, this is what you would see, more or less. This is a diagram showing the structures in the lateral wall. There are these 3 conchae or turbinates, these long folds of bone, very thin bone, that protrude in from the lateral walls of the nasal cavity and provide a surface area for the nasal epithelium, this pseudostratified columnar epithelium, and which humidifies the air that you're breathing in and warms it before it goes down towards the trachea. The turbinates are actually quite long. The lowest one of them is about the same length as your index finger. So they're quite long structures. Now, we don't need to know the detail of where the various sinuses drain into, but there's a number of different things that drain into the central part of the nose through this lateral wall. So the sphenoid sinus drains from the front of the sphenoid sinus just right into the roof of the nasal cavity. The frontal sinuses, maxillary sinuses, and ethmoid sinuses drain beneath the middle concha, the middle one. But the nasolacrimal duct, the duct that drains tears from your eyes, comes out below the lowermost of the three conchae. The structure at the back of the nose there is the opening of the eustachian tube. So those are the important structures on the lateral wall of the nasal cavity. Now, sensation of the lateral nasal wall, as we mentioned earlier, the maxillary nerve is responsible for most of the sensation within the nose. And so the lateral wall of the nose, all the pink area shown here, is innervated by the maxillary branch of the trigeminal. In front of that, though, the area that I've shown in blue here is innervated from a branch of the ophthalmic nerve. And that's, if you remember when we looked at the ophthalmic division of the trigeminal nerve, it has 5 branches on the on the skin that we need to know about. And one of those is the one that goes to the tip of the nose, which is the anterior ethmoidal nerve. And the only reason that's clinically significant is that if you get shingles affecting the anterior ethmoidal nerve on the tip of your nose, then you almost certainly will get involvement of the conjunctiva as well, because it's connected in it's the nerve supply, the nerve arrangement. And the anterior ethmoidal nerve comes off a nerve called the nasociliary, and the nasociliary has a branch to the conjunctiva. And so the nasociliary does this blue area inside the nose, lateral wall of the nose, and also does, as it comes out through the skin, it's the anterior ethmoidal nerve. So that's the sensation of the lateral wall. The remainder, of course, is V2, which is the maxillary division of the trigeminal. Now, a popular exam question is Little's area and the blood supply to Little's area. Of course, we all know that if you look at the blood vessels in this is in on either side of the septum, in the center of the nose, there's a rich interconnection of blood vessels. Of course, the nasal cavity has a good blood supply. In older patients, a lot of the bleeding is venous. A lot of epistaxis in older patients is venous, and it's from the lateral walls of the nasal cavity. But in younger patients in particular, it's from the medial wall. It's from one side or another of the septum. And this rich network of vessels is known as Kieselbach's plexus. And Little's area is the sort of anterior area just inside the nose is Little's area, a common site of trauma. Now, for the primary exam, you, of course, can only write true and false, so you're not expected to remember the names. So what I'm going to do is I'm going to go through, there are 5 vessels that form Kieselbach's plexus, and I'm just going to go through perhaps a way of remembering them, just so that if you get them listed in a question in the exam, you might recognize the ones that are part of Kieselbach's plexus and any others that are put in that aren't. So if we go sort of in a clockwise direction, we've got a blood vessel coming from the sphenoid direction, top left. We've got something coming from the ethmoid direction, top right. And in fact, we've got 2 coming from that direction. We've then got something coming from the direction of the lip, bottom right, and something from the direction of the palate, bottom left. So if you just think about those 4 directions, there's 2 come from the ethmoid direction and 1 each from all the others. And so when we come to the names of the individual arteries, the one from the sphenoid direction is the sphenopalatine artery. Then there's 2 from the ethmoid direction, and they are simply the posterior and anterior ethmoid arteries. Then we've got 1 from the lip direction, the superior labial artery, and 1 that goes across the palate before going through a hole in the hard palate, in the bony palate, and opening into the nasal cavity, the greater palatine artery. So those are your arteries that form Kieselbach's plexus, And it's, again, as I say, it's clinically important because there's lots of vessels, and so treating an epistaxis can be challenging because of all the potential sources of the blood supply. These are all ultimately branches of the external carotid, and it's not unknown for the external carotid to need to be ligated in order to control bleeding from an absolutely torrential and uncontrollable epistaxis. The college indicates we need to know about the paranasal sinuses and about their development. So, of course, there are we'll talk about it as four groups. There's the paired frontal sinuses. There's the sphenoid sinus deep in the head around the pituitary fossa. There's the largest, which are the maxillary sinuses, and then there's the ethmoid sinuses. Now, the ethmoid sinuses, there's no specific number of those, but they're often referred to as ethmoid air cells because there are so many of these little cavities connected together. So there's several ethmoid sinuses on each side, and they're just medial to the eyes, to the orbits, lie in the midline. They are an important source of orbital cellulitis. If you get a sinusitis in the ethmoid sinuses, then the bone that separates the ethmoid sinuses from the orbits is extremely thin. The lamina papyracea, if you remember that, it's a very, very thin wall of bone, and it's no distance at all for infection to travel and get into the orbit and can cause a very serious infection. So those are the paranasal sinuses. Now, what about their development? Well, college curriculum indicates that we need to know when these sinuses develop. Well, I've listed on this slide here what is usually the accepted position, which is that the ethmoid, maxillary and sphenoid sinuses are all present at birth, and the frontal sinuses develop later, around 10 years of age. In reality, it's not that we are born with the sinuses of the size that we have them as an adult. What happens is they're very tiny at birth, and then gradually they expand and grow into the bone and become larger and become aerated and develop over life. And they're quite variable in the progression and so on. But they are present from birth, apart from the frontal sinuses. Now, the frontal sinuses, are very variable. Some people may not develop, of course they're a pair, left and right, and some people may not develop one of their frontal sinuses, and some people have much more extensive frontal sinuses than other people. The college also requires us to know something about teeth development. So, of course, there are 8 teeth in a full set: upper left, lower left, upper right, lower right. So there's 8 in a full set. There's 2 incisors on each side, then a canine, then 2 premolars, and then 3 molars. And we're expected to know something about the age at which these erupt. Now, of course, there's a first set of teeth, the deciduous teeth, which I haven't listed here. These are the permanent teeth only that I've listed here. So the first of these, the central incisors, appear at about 7 years of age, 6-7 years of age. Then that's the very central ones. The ones immediately lateral to those appear about 8, then the canine about 10, and then the 2 premolars, slightly different times, but around about 11. Then if you come to the molars, then it's almost like you start back a bit earlier again, because the first molar appears early, not long after the central incisors, at about 7 years. But then the second molar is much later, at 12, and the wisdom teeth, as we call them, the third molar, anything from around very roughly 20 years of age, but it's extremely variable when the final molars arise. And of course, many people have lose teeth or have teeth taken out. But those are the eruption ages for the permanent teeth on average. But each of those has a significant variation from person to person. The college expects us to know a little bit about dental anesthesia. Now, probably the commonest nerve block in the world is the nerve block for dental work on the lower teeth, and many of us will have had this done. and it involves the inferior alveolar nerve. Now, we talked about the maxillary nerve. We mentioned that there are two, in fact, superior alveolar nerves, anterior and posterior, but there's one inferior alveolar nerve which runs in the mandibular foramen, which I've shown here on the inside of the mandible, it's just below, below the joint on the inside of the mandible, and then it runs in a canal underneath the teeth, before finally the nerve emerges out through the mental foramen into the chin area and provides sensation for the skin over the chin. So that's the inferior alveolar nerve, and if you're going to anesthetize that with a block, then the process is to take some local anesthetic and then put a needle in through the mouth and aim for a position in the lining of the mouth behind the most posterior molar tooth. So you aim to deposit some local anesthetic under the mucosa in this area, and then it will spread. And of course, as well as anesthetizing the inferior alveolar nerve, it will also, of course, give you an area of sensory loss over the chin because of the mental nerve. And it's not unusual to also, if you put a large quantity in, if it spreads, for it also to affect other nerves as well, like the lingual nerve, to give a numbness of the tongue. So that's a little bit about dental anesthesia in the lower jaw. Now, when it comes to the upper jaw, there's not an easy way of anesthetizing the upper jaw teeth, and so it's usual to do anesthesia locally around each tooth into the actual mucosa. There are ways of getting more deeply at branches, but they're more difficult. One that is achievable is the infraorbital nerve. When we looked at the infraorbital nerve previously, where it emerges just below the eye, you remember the anterior superior alveolar nerve penetrates deeply through the bone of the upper jaw, just from a point just inside the infraorbital foramen. And therefore, if we can get a decent amount of local anesthetic into the infraorbital foramen, it will disperse and spread in, and also reach the anterior superior alveolar nerve and give numbness of the anterior teeth, the canines and the incisors on that side. But the molars, it's more difficult in the upper jaw. So that's a little bit about dental anesthesia. The college curriculum includes that as a subject. Now, this diagram here is actually shows a little bit about the tongue, because we need to know some of the structures around the tongue. So the college wants us to know a little bit about the nerves around the tongue. We're not expected to know the detail of all of the intrinsic and extrinsic muscles of the tongue, which is great because they're quite complicated. But we are supposed to know a little bit about the floor of the mouth. And here there are three nerves that are relating to the tongue that are important to us. And we've already looked at these when we looked at taste and sensation for the tongue. And of course, the tongue embryologically has an anterior 2/3 and a posterior 1/3. So the hypoglossal nerve, which is the 12th nerve, that's this one here. The hypoglossal nerve, that's the 12th nerve, that's this one here. That's, of course, a motor nerve. It's the one that innervates all of the muscles, intrinsically and extrinsically, to do with the tongue. The next one above it here is the glossopharyngeal nerve, which is the muscles shown there are the constrictors, and we'll come to those of the pharynx. But the glossopharyngeal nerve, very important in the sensation of the pharyngeal wall, but also of the back of the tongue. So the posterior 1/3 of the tongue, both taste and sensation of the posterior 1/3 of the tongue travel in the glossopharyngeal nerve. And then finally at the top here, we've got the lingual nerve, which is the branch of the mandibular division of the trigeminal, and that we can see that winding down below here we've got the submandibular gland and the submandibular duct, and the lingual nerve winds below the submandibular duct and into the tongue. And of course the lingual nerve has picked up the chorda tympani, which carries the taste fibers from the anterior 2/3 of the tongue, and the lingual nerve itself does normal sensation to the tongue, touch and temperature, etc. for the tongue. Okay, so those are the structures around the tongue that we need to know about. The bone here is, of course, is the mandible that's been cut through at the front, and then we've got the hyoid bone beneath the tongue with a number of muscular structures going from the tongue to the hyoid. Looking down at the tongue from above into the floor of the mouth, there's a couple of structures here that we need to be aware of. So here's the submandibular gland. So the submandibular gland is just underneath and medial to the jaw. It's palpable sometimes when it's inflamed or enlarged, just below the angle of the jaw. And the submandibular gland has quite a long duct, which is shown here in light blue, which travels anteriorly before emerging very close to the midline at a thing called the caruncle, very close to the midline underneath the tongue. So you lift up someone's tongue and you can see the opening of the duct. And of course, if a stone forms within the submandibular gland and then travels down the duct, it can often become obstructed just before the orifice of the duct. And that's a common site for the stone to become impacted. Just close to the opening of the submandibular duct are the sublingual salivary glands. Now these are actually considered to be a group of glands, 15 to 20 discrete glands on each side, each with a series of little openings into the floor of the mouth, and also one larger duct that actually joins the submandibular duct. So the sublingual glands, the series of them on each side, 15 or 20 of them. And of course the submandibular and the sublingual glands, both innervated by the parasympathetic via the mandibular nerve and the submandibular ganglion. Now the muscular pharynx, the process of swallowing is a complicated one, and the pharyngeal muscles, the muscular pharynx, are a series of three. They're often talked about as sitting one inside the other. The superior, the middle and the inferior constrictors of the pharynx. When we eat and we initiate swallowing, the start of swallowing is under voluntary control. So in the process of swallowing, a bolus moves towards the back of the mouth, moistened with saliva and so on. And then once it gets to the back of the tongue forms a trough in the center of the tongue. And then once the bolus hits the pharyngeal wall, the posterior pharyngeal wall, then the involuntary process of swallowing takes over. And this reflex activates the constrictors and also a whole lot of other complex muscular actions. So in the process of swallowing, the constrictors are going to create pressure to force the bolus down towards the esophagus. But of course, at the same time, you've got all these other potential openings. The bolus could move back to the mouth, up to the nose, or down to the larynx. So all of those have to be closed off. The tongue closes off the mouth, the soft palate closes off the nose, and the larynx rises and the larynx closes. And that then allows the constrictors to move the bolus down towards the esophagus. And from then on, all of it is involuntary. A series of actions take place which we have no voluntary control over. And that's largely innervated by the glossopharyngeal and the vagus nerves. If we look at the pharynx and anatomically and talk about some of the structures of the pharynx, first of all, just to mention the tonsils. The tonsils sit in the oropharynx between the pillars of the fauces. And then, of course, we've got other aggregations of lymphoid tissue. So the adenoid, it's a midline structure, sits close to the eustachian tube opening shown there. And that's in the nasopharynx. And so the nasopharynx is this area from behind the nasal cavity down to the bottom of the soft palate. And then we've got the oropharynx, which is the area around the tonsil, in front of the soft palate, behind the uvula. And then finally we've got the hypopharynx, which is the area below the nasopharynx down to the level of the larynx and the opening of the esophagus. So these are these different anatomical areas. Moving down to the larynx, this is an image of what you might see if you looked at the larynx from behind and cut open the back of the pharyngeal wall. And so at the top here, you've got the tongue, seeing the back of the tongue here. Then the space between the back of the tongue and the epiglottis is known as the vallecula. That's the cavity there. Then you've got the epiglottis, of course, and we'll be looking at the cartilage for that in a moment. And then on either side of the larynx, you've got a piriform fossa, one on each side of the larynx, place where food can lodge and things can get stuck in the piriform fossae. Usually it's held tightly against the side of the larynx. The mucosa touches, but things can get lodged in the piriform fossae, and they normally would otherwise drain down towards the esophagus. So those are the structures in the larynx. And if we look at the laryngeal skeleton, the cartilaginous parts, there's a cartilage in the epiglottis. Then you've got the large thyroid cartilage, and then you've got the arytenoids, and these are important in the action of the vocal cords. The arytenoids, there's a number of intrinsic laryngeal muscles that attach to them and activate the vocal folds, the vocal cords. And then finally the cricoid cartilage, which is the only part that's a complete ring. All the tracheal rings below that, of course, are incomplete at the back. They have the trachealis muscle that can control the size of the trachea, a smooth muscle across the back of the tracheal rings. And the thyroid cartilage, of course, is an incomplete ring also. But the cricoid is a complete ring. It's taller top to bottom at the back than it is anteriorly. If we look at the laryngeal view, this picture at the top here shows what we would see with a laryngoscope looking down at the larynx itself, and we can see here the epiglottis and then the pale coloured vocal folds, often known as the true vocal cords, and then above them a mucosal fold known as the false vocal cords. And then through the cords we can see the tracheal rings into the distance and the lining, the mucosal lining. Now, just to say a word or two about the function of the vocal cords, they're innervated, of course, by the recurrent laryngeal nerve on each side, which comes, of course, from the vagus. And we've gone in detail into the anatomy of that and how they hook around major vessels. Now, they are quite vulnerable nerves. The recurrent laryngeals can be damaged in surgery, for example, on thyroid surgery, and also can be invaded by tumours arising from the head and neck and metastasizing to lymph nodes in the neck. So recurrent laryngeal nerve palsy is one of those things that we need to look out for, and it often presents as hoarseness of the voice or a deepening or coarsening of the quality of the voice. Now, we're not going to go into the detail of the movement of the true chords, and the college doesn't require us to do that in the curriculum. We just need to be aware of the issues relating to vocal cord paralysis. Now, broadly speaking, the functions of the recurrent laryngeal nerve in the larynx can be divided into phonation, which is where the chords are brought together, and the respiratory function with muscular activity bringing them apart. So when we breathe, we want the chords open. When we speak, we want them together. So if we look at the pictures down at the bottom left hand here, this is what would happen if you had either a unilateral or a bilateral paralysis. So during breathing, you would have a problem with opening them. And so if they're both paralyzed, the chords will nearly meet in the middle, and there'll be stridor, and there may be difficulty breathing. And when you're phonating, when they're both paralyzed, they do come together, although they can't be held taut. So there's the hoarseness and coarsening of the voice, and unilaterally, one side, the affected side here is shown on the right-hand side, can't be brought towards the middle. So phonation and respiration, two different functions. So phonation, adduction, respiration, abduction of the chords, and both of them are lost if you have recurrent laryngeal nerve palsy. So the college wants us to know the bones of the orbit. I'm not quite sure why the curriculum wants that, but it does. So let's just go through the bones of the orbit. There are a number of different bones that form the bony socket for the eye. So obviously at the top here we've got the part of the frontal bone. The bottom we've got a large part of the maxilla, which makes much of the floor of the orbit and of course encloses the maxillary antrum. And that's the orbital floor, the part that gets damaged when you have a blowout fracture. So if you have a projectile hits the eye, classically it's a squash ball, then the force acting on the floor of the orbit can break into the roof of the maxillary sinus, and obviously that's part of the maxillary bone. Out on the side here we've got the zygoma, the bone that forms the prominence of the cheek, the bone that takes the force if somebody's receives a blow to the side of the face, a thump, then the zygoma takes the force, and often the zygomatico-frontal suture line, so where the zygoma and the frontal bone meet, is often disrupted in blows to the maxillary complex. The back of the eye we've got part of the sphenoid complex bone, then on the medial wall at the back we've got part of the ethmoid bone, and in front of that part of the lacrimal bone. So there we are, those are the bones that make up the orbit. Right, now the eyelids are quite important clinically because of the issue with infection and the spread of infection from infections within the eyelid and around the eye. So let's just go over some of that. And it relates to this structure known as the orbital septum. So the orbit, the eye, is held within it, of course, by the soft tissue structures, muscles and so on, and then a diaphragm closes the front of the orbit. This is made of the orbital septum, which attaches from the bone initially, and then two tarsal plates, one in the upper eyelid and a smaller one in the lower eyelid. And these structures form a complete sort of diaphragmatic structure across the front of the eye. So when the eye is closed, there is a complete separation by the orbital septum and the tarsal plates. The tarsal plates are sort of cartilaginous structures. The orbital septum is a fibrous structure. And we talk about orbital cellulitis as being preseptal or postseptal. And that all relates to the orbital septum. So for example, when you have an infection in the root of a hair, and we'll look at where the roots of the hairs are in the next slide. If you have a hair follicle infection, so a stye as we used to call it, then infection can track up the front of the eyelid, but the orbital septum and the tarsal plate stop it from penetrating more deeply. And that's what's known as a pretarsal. That's what's known as a preseptal infection, and separates it from orbital cellulitis. So orbital cellulitis is internal to the orbital septum and the tarsal plate, and that tends to come from the ethmoid sinuses, for example. Much more significant condition, much more likely to cause infection within the globe itself, more likely to affect the optic nerve and so on. So the orbital septum, an important barrier to infection. It tends to be younger patients who have preseptal infections and older who have postseptal orbital cellulitis. Okay. Looking at the eyelid in more detail, here's the eyelid blown up, and I just want to, so the tarsal plate is still shown in green here, and then in front of it we've got the eyelash and the skin and so on, but behind the tarsal plate, just at the opening of the eyelid, we have these structures called the meibomium glands. There are about 20 of these along the upper eyelid and along the lower eyelid, just inside the margin, opening by small glands, by ducts, onto just to the very edge of the lid margin. And the meibomium gland produces a lipid-based secretion, a fatty secretion, which really just comes to run on the edge of the eyelid and keeps the more aqueous tear solution more internal, keeps it contained. The lipid content, the hydrophobic nature of the lipid content, maintains that more aqueous tear film from running out into the what's known as the palpable fissure, the area that's open, the area of the eyeball that's exposed to the outside. So it helps to contain the tears. That's the meibomian gland. Of course, the meibomian gland ducts can become blocked and form a meibomian cyst, what also used to be called a chalazion. Here, just outside the tarsal plate, we've got bundles of the orbicularis oculi muscle, which of course acts like a sphincter around the eye, and it's the muscle we use when we clench the eye tightly closed. Okay, turning to the tear production and drainage. So tears are produced in the lacrimal gland, which sits, shown in blue here, sits laterally with the ducts opening into the sac, the conjunctival sac, and producing the tear film over the eye. And then the tear film gradually moves medially and drains through the nasolacrimal canaliculi. There's two, an inferior and a superior one. And from there they drain into the nasolacrimal duct. And the nasolacrimal duct, of course, drains downwards, and it has its opening below the inferior concha, or the inferior turbinate as it's also known. So that's the path of the tears. The lacrimal gland, as we discussed previously, innervated by parasympathetic fibres which have their synapses in the pterygopalatine ganglion. And so the parasympathetic motor fibres to the lacrimal gland arising from there. The other parasympathetic fibres in the eye, of course, the ones that involved in the pupil, they cause narrowing of the pupil, and they have their synapses in the ciliary ganglion at the back of the orbit. Just coming to the external ocular muscles, of course there are 6 of these, and 4 of them are fairly sort of obviously arranged around the eyeball, one at the top, one at the bottom, one on each side, which of course are the superior, inferior, medial and lateral rectus muscles. But then we also have these rather odd other muscles, the superior and inferior obliques. Now, just looking at the superior oblique, what it does is it comes up to the top of the orbit on the medial side and then passes through a ring, passes through a sling before attaching obliquely across the eyeball. So it has a number of functions. It's able to turn the eye downwards. It's also able to abduct the eye because it sits behind, it inserts behind the equator, behind the midline of the eyeball. If you think of it in the plane of the face, because it inserts more posteriorly, then its action will turn the eye outwards. But it also rotates the eye inwards. And you might wonder, well, when do we need that? When do we need the ability to rotate, to spin the eye? And that happens when we tilt the head. When we tilt the head sideways, in order to maintain a vertical image, the eyes have this ability to tort. It's called torsion. And so the eye torts. So those are the functions of the superior and the inferior oblique. The inferior oblique is also an abductor because of its posterior location. So we've also, and then here we'll add in the lateral rectus, and here's the inferior oblique. So there's 6 extraocular muscles. Now, of course, these are a very popular subject for anatomy questions in the exam, palsies relating to the external ocular muscles. Of course, the ocular motor, the third nerve, innervates everything except for the lateral rectus and the superior oblique. And the lateral rectus, of course, is the 6th nerve. It's the abducens, and the superior oblique is the trochlear nerve, the 4th nerve. So those are the 3 nerves involved in movement of the eyes, the external ocular muscles. If you have, let's just go through lesions of these one at a time. If you have a lesion of the abducens, the 6th nerve, and that can be, for example, a false lateralizing sign, a raised intracranial pressure because the 6th nerve has a long intracranial course, just pressure on it can cause it to misfunction, and you can get a lateral rectus palsy. So if you have a lateral rectus palsy, then you can't turn your eye outwards properly, and so all of the other muscles turn the eye inwards. And that eye, any image on the eye, will actually end up falling on a more lateral part of the retina than it would have done. And so it will create an image that appears more lateral than it should. So lateral rectus palsy will create a diplopia, a double vision, and it will be a double vision in the horizontal plane. That is, the extra image will be horizontally displaced from the normal image from the other eye, and it will also be more extremely placed. It would be more lateral. So you'll get a horizontal diplopia if you have an abducens palsy, a sixth nerve palsy. That's much commoner than a fourth nerve palsy. If you have a fourth nerve palsy, the superior oblique being affected, what happens then is that the patient gets a vertical diplopia. The abnormal image, because the superior oblique has the ability to turn the eye downwards, the eye ends up more vertically orientated, and so you get an extra image which is displaced in a vertical plane, and that image will come to lie more peripherally, as if the image had come from a higher position. So you'll get a vertically displaced image, a vertical diplopia. Finally, if you have an oculomotor nerve palsy, a third nerve palsy, well, the classical appearance of a patient with an oculomotor palsy is that the eye is down and out. So the remaining action from the trochlea and the abducens cause the trochlea turns the eye downwards and the abducens turns it laterally. And so the eye is down and out. And so that causes a very severe diplopia. So those abnormalities of the cranial nerves and the external ocular palsies are a popular exam question. Another area that the college has in the curriculum is to do with the optic nerve. Now, I'm not going to say a great deal about the optic nerve. Most of it is fairly well known in terms of its function, carrying, of course, the fibres from the retina. But one of the things that's important about it is that it does have an extension of the meninges over it. So all three layers of the meninges run over the optic nerve right the way to the back of the eye. So here you've got in purple, you've got the pia, in blue you've got the arachnoid, and then in green you've got the dura mater. But you've got the three layers, and of course in the subarachnoid space you've got the CSF. And so if you have raised intracranial pressure, you're going to have a raised pressure within that subarachnoid space around the pia and around the optic nerve. So therefore, you're going to have a raised pressure. You're going to have pressure on the optic nerve, and that can cause optic atrophy and so on, and cause problems in the long term. But in the short term, it affects the venous drainage coming down along the optic nerve, and so you get venous engorgement in the back of the eye, and that's the papillary edema that we associate with raised intracranial pressure. So this is the mechanism by which raised intracranial pressure causes papillary edema. It's because of that extension of the CSF around the optic nerve. Okay, my final subject, and I'm not going to say a great deal about the middle ear, but it's about the middle ear. So here's a sort of stylized image of the middle ear, as if you were looking at the ear from the front, looking at the patient's right ear from the front. Obviously the blue is the tympanic membrane, and onto that is the handle of the malleus. Now the curriculum only requires us to know about the handle of the malleus because that's what we see through the otoscope. It doesn't require us to know about the incus and the stapes, the other two bones. So it's the handle of the malleus is what we see. And of course, the stapes ultimately communicates with the cochlea through a window on the medial wall. Now, through the middle ear passes the facial nerve, and on its way to the zygomastoid foramen, and then on through the parotid gland. And just as it goes through the middle ear, it gives off the chorda tympani, which of course combines with the mandibular nerve and travels down and supplies taste to the anterior 2/3 of the tongue. So those are some structures within the middle ear that we need to be aware of. just looking at a couple more structures around the middle ear. So here we have the inner ear more medially with the cochlea and the semicircular canals, provided with innervation through the 8th nerve, the vestibulocochlear nerve, which we test, of course, by testing for hearing. We can, of course, test also the vestibular function using cold water, for example, though we don't do that as part of a standard cranial nerve examination. We only test the acoustic part, the ability to hear, and we, of course, can test conduction through air as well as and also through bone using Weber's and Rinne's tests. So that's the cochlea and the semicircular canals. And just to mention two other openings that come off the middle ear, one of course is the eustachian tube, also known as the auditory tube or the pharyngotympanic tube, which equalizes pressure between the middle ear and the pharynx. It opens in the nasopharynx near to the adenoid, and of course is the means whereby the pressure is equalized either side of the tympanic membrane, shown in blue here, and prevents rupture of the tympanic membrane if there's a disparity in pressure. On the other side of the middle ear, we have a communication with the mastoid air cells. So the mastoid bone, of course, it has air cells in it, it's hollow, and historically it was an important site of infection. We hardly see it these days, but historically middle ear infection would spread occasionally to the mastoid air cells, causing mastoiditis, and that could be a very serious suppurative infection and could spread from there into the brain. So mastoiditis was seen as a very serious suppurative problem in the past, and it was not unusual to actually make a hole into the mastoid and allow the pus to drain out to the surface. We hardly see it anymore. So those are just some structures within the inner ear that we need to be aware of. The final subject in this webinar is the temporomandibular joint, the TMJ joint. And this is important because it has a more complex structure than you might imagine. It has both a rotational hinge-like action but also a sliding action. So if you look at the TMJ in this image here, you'll see that there's a green coloured cartilage that sits between the two parts of the joint. Effectively, that divides the joint into two separate joints. The lower joint, both of them are synovial joints. The lower joint is the joint that allows rotation, and the upper joint is the joint that allows forward movement and sliding of the condyle. So if we just go step at a time through the process of opening the mouth, if we move to the next slide, when the mouth opens up to 20 millimeters between the teeth, as in this picture here, what happens is that the condyle rotates and the cartilage stays in its original position. But when moving beyond this point, we now see that the cartilage has slid forward from its original position in the groove in the joint and has moved forward. So we've got a combination here of both the rotation and of the sliding movement. And the presence of this cartilage is what accounts for some of the problems clinically with dislocated joints. So some patients sometimes present with a jaw that's stuck open, and that's because of disorders to do with this cartilage, the cartilage being displaced, etc. So that's the TMJ, and it's combined two joints within one capsule.